Then we discussed and decided I'll try to touch most of the part in short, and then probably in the next season or sometimes later we'll go to the individual aspect of the tetralogy. In between my presentation, Amresh and Sanjeev sir, so there is some story, because I always love to tell stories in between presentation. So please ignore that story part as timing. So thank you so much for giving me the opportunity, and let me start. Tetralogy, described it in the year 1888. So it's long back, and between 1888 up to 1945, there was nothing which progressed. Though anatomically we progressed a lot, but no one could venture to do something in terms of treatment. So Dr. Fallot, you should know the full name. Let me tell you one story. So when I was giving my MCH exam, I completed all my answers. I was just coming out. Then the external examiner it and asked, please tell me what is the full name of Fallot, because he wanted me to go outside again with mind that this fellow could not answer this. So can anyone answer what is the full name of Dr. Fallot? I think many of you might be knowing. Etienne Louis Arthur Fallot. So he is the cardiologist who described tetralogy of Fallot. Tetra means four. So four components of a single disease he described, and it is described in this picture. There are four components: ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and overriding of the aorta. And being a student, when you are appearing the exam, never say, when the examiner will ask, tell me the four components of tetralogy of Fallot, never say overriding of the aorta or RVH as the first answer. Usually external doesn't like this type of answer. So the most important component of tetralogy of Fallot out of four are pulmonary stenosis and ventricular septal defect. So whenever you are answering, start from ventricular septal defect or pulmonary stenosis. Now coming to a little bit of the story. I'm sure many of you might have seen this movie, Hollywood movie, something the Lord made. There is another movie, The Partners of the Heart. If you go back to the history, probably you will know the complete history of congenital heart surgery starts from these two movies, and everything is explained in that. There are three geniuses in this. The black genius, who is Vivian Thomas, Dr. Blalock, and the cardiologist is not there in this picture, Helen Taussig. So the story is like this. They were doing research in the lab where this Vivian Thomas used to stand and watch. So they did lot of experiment how to improve the blood flow to the pulmonary artery. Various experiments on animals they did, and finally the day came when one child came with cyanotic spell and they wanted to do BT shunt. During that times the cardiologist was not in the town, so Dr. Blalock was alone. Then he called Vivian Thomas and he said, you are the only support for me because you know what I am doing for the last so many years, and you are the only person who can guide me when I am doing the surgery. So can you please stand behind me and help me out if I am doing something wrong? So this gentleman, he agreed to that, and then this is the very rare picture where the Vivian Thomas is standing behind, because Dr. Blalock is operating. He asked him to stand behind, and in case he is doing any wrong step or taking bites which is very wide, he has to alert that, correct it. And he has explained everything in his biography, that how he supported Dr. Blalock when he was doing the surgery. And later John Hopkins gave him the doctorate degree in 1964 or 65, something like that, and he became a doctor. So now coming to the original topic. So tetralogy of Fallot is a most common congenital heart disease, congenital cyanotic heart disease, where the incidence is around 7 to 10% of total congenital heart diseases, with equal proportion in males and females. And there is a syndrome which is commonly associated is DiGeorge syndrome. If the parents are having phenylketonuria, the children are more prone for tetralogy of Fallot. And if there is history of maternal alcohol intake during pregnancy, then also they develop tetralogy of Fallot in the children. Little bit about the embryology. It is very boring, but still I'll try to touch the little bit part. So initially, during 5th week of intrauterine life, two ridges appears in the truncal part. One on the right superior aspect here and one in the left inferior aspect. Then what happens? The rotation starts in this truncal segment, and then foreshadowing the spiral course of the septum in the future. Then after completion of the fusion, the ridges form the aorticopulmonary septum and then divides into two components, aortic component and pulmonary component separately. So tetralogy, this is a very common concept. You have to understand this and you have to answer when it is asked in the exam. It is because of unequal division of the conus resulting from anterior displacement of the conoventricular septum. So it is anterior displacement of the septum which can cause this particular subset. There are various variants of tetralogy of Fallot, but I am going to touch only the tetralogy part because of shortage of time. So it can be pulmonary atresia VSD, it can be pulmonary atresia VSD with MAPCAS, it can be DORV, it can be absent pulmonary valve syndrome. So each one is a big topic. So I am trying to stick to tetralogy of Fallot. Coming to the morphological part, if you appear the exam, you must be aware of this fact that the examiner may ask you describe the VSD in tetralogy of Fallot. That is very important question and very common question being asked. So what is the description of VSD in tetralogy of Fallot? It is large, non-restrictive, malaligned perimembranous VSD due to anterior and leftward deviation of the conal septum. That is the complete answer for this VSD to describe. So what are the margins? Superiorly, this is RVOT, this is the superior area, this is the VSD. So superiorly it is infundibular septum, inferiorly and anteriorly it is by septal band, and posteriorly it is by anteroseptal leaflet of the tricuspid valve. Then it is very important to know, as Dr. Reddy said, that where the bundle goes, especially in case of tetralogy of Fallot, the VSD is very large. So while closing the VSD, you are going to put a big patch. So that is the reason it is very important to know where exactly is the location. So this is again a question. It traverses through the posterior inferior edge of the defect. So this is the bundle where it is going, and this is the perimembranous area. So where while putting the patch, you have to be away from this. So normally what the surgeons does, they don't stick to the margin. They take the bite away from this area and superficially, so that this bundle area they can avoid. So while taking the bites on the posterior inferior aspect, you have to be very careful. Other areas it is okay, you can blindly put the suture, not a problem. Coming to the morphology of the pulmonary valve, in tetralogy of Fallot, if you will see, the pulmonary valves are usually thickened. There will be commissural fusion and there will be supravalvular tethering. So if you will see these pictures, this is a typical picture of tri-leaflet valve. This is one leaflet, this is one leaflet, this is one leaflet, this is bi-leaflet valve. So in this tri-leaflet valve, if you will see, this is the supravalvular tethering and the commissures are fused, making it a small lumen. Ideally it should be something like this, but it has become like this because of fusion of the commissure and supravalvular tethering. And most of the cases it is bicuspid. So what we do during surgery, I'm touching little bit of surgery here because I'm not going to take much time during description of the surgery. So surgical aspect, what we do, we release this supravalvular tethering, and then we do commissurotomy like this and make the openings, the effective orifice area wider. So supravalvular tethering release and commissurotomy, these two are very important aspect of pulmonary valve repair, or pulmonary valve tackling the pulmonary valve in case of tetralogy of Fallot, if the annulus is normal. If the annulus is small, then of course you have to put a transannular patch. In that case, this leaflet repair doesn't matter. Then peripheral pulmonary arteries, it is again a very good assessment to know whether the patient needs palliative surgery or corrective surgery. There are various indexes. I am not going into the detail. Nakata index, McGoon index. Based on that, you can decide whether we need to do palliation or we need to do surgery. But majority of the surgeons, they prefer to do early surgery rather than palliation. So there can be associated hypoplasia of the pulmonary arteries, either LPA or RPA or both. Mostly it is associated with LPA origin stenosis, which is almost like 40%. Stenosis at both arteries at the origin or maybe in the mid segment, and sometimes LPA takes origin from the ductus. Associations are pulmonary atresia, absent pulmonary valve, as I said earlier, I am not touching that. Now overriding of the aorta, again it is due to dextroposition of the aortic root. So normally in all tetralogies you will find there will be overriding of the aorta. If the grading becomes more and more, it goes towards the subset of DORV, and if it is completely rotated, that goes to the subset of TGA. So it is a spectrum which starts from tetralogy, ends in TGA. Now the coronary anomalies associated with tetralogy of Fallot are various types, but most common is conal branch crossing RVOT, which is here. You can see this is a large conal branch crossing this area. This is RVOT area. So conal branch crossing RVOT, that is the most common variant, which constitutes almost 40% of the cases. And the second most common is LAD crossing RVOC, single coronary arising from the right sinus and the LAD crossing all the way across the right ventricular outflow tract. And this is again a subset where you cannot straight away go for correction. So this constitutes almost 5% of the coronary anomalies. Coming to the pathophysiology, I am not touching in detail about this. Normally what happens, there will be pulmonary stenosis, and initial phase there will be bidirectional shunting and sometimes predominantly left to right. As the stenosis increases more and more, so what happens, there will be hypertrophy of the muscles instead of chamber enlargement. So this hypertrophy causes increase in pressure on the right side. As the pressure in the right side increases, so right to left shunting becomes more and more. And finally that stage comes when the right ventricular pressure crosses the left ventricular pressure and there will be completely right to left shunting. That is the time when the cyanosis develops. So severity of cyanosis is directly proportional to severity of pulmonary stenosis. But usually they don't develop congestive heart failure because the VSD is very large and it completely decompresses the right side and protects the heart from developing congestive heart failure. Now coming to the symptoms, how this kids presents, usually the most common symptom is cyanosis. You can see in early stage in a neonate, there will be complete blueness of the palm, nail beds of the hand and feet, lips, then sole, and then what happens? These kids, if you are not treating them properly, usually they are more prone for developing TET spells. So if it is a bigger patient, then they develop easy fatigability, dyspnea on exertion, failure to thrive. So if there is any cyanotic, I'll come to the details of cyanotic spell. If there is any cyanotic spell, usually kids prefer to sit in this position, which is called squatting position. And in squatting position, they increase the systemic vascular resistance so that their pulmonary blood flow becomes more and the symptoms get relieved. Again, there is another postgraduate question how you describe the VSD. Like that, what is cyanotic spell? It is very important to describe in all points when you are describing about cyanotic spell. So sudden onset of dyspnea, sometimes gasping respiration and syncopal attack. Sudden deepening of cyanosis, leading to altered consciousness from irritability to syncopal attack. Sometimes in later stages they can develop convulsion and hemiparesis also. So at that particular time, temporarily you will not find any systolic murmur because there will be complete absence of blood flow through the pulmonary artery. So there will be no murmur at all, and they develop metabolic acidosis. And when it develops usually in response to crying, feeding, defecation, agitation, fright and all. And what happens? During that time, the pulmonary vascular resistance increases, there becomes more, and right to left shunting becomes more, and the patient becomes fully cyanosed. So what to do during that time? It is very important how to treat TET spells. So you have to press the knee towards the abdomen, flex the hand, keep in knee chest position, start giving some volume, probably around 10 ml per kilo volume, and again you repeat after 10 to 15 minutes. Correction of acidosis, if there do one blood gas, if there is any acidosis, try to correct the acidosis. 1 milli equivalent per kg you can calculate and give bolus, and again you can repeat after 10 to 15 minutes till the time acidosis is corrected. Then you can give morphine. So how morphine helps? It calms the child, and at the same time it depresses the respiratory center. When it depresses the respiratory center, that time the cycle of hyperapnea reduces. So that breaks the cycle of cyanotic spell. You can give some beta blocker and you can give ketamine. So in severe cases, ketamine works. So they develop with, in the later stage, they develop with clubbing of fingers and toes. On auscultation, you will find a ejection systolic murmur. Always remember, usually the murmur of tetralogy of Fallot is not because of VSD, it is because of pulmonary stenosis. So ejection systolic murmur in the left lateral border of the heart, and you will find single second heart sound because the pulmonary component of the second heart sound will be very soft. Then if you do the X-ray picture shows something like this, which is called boot-shaped heart. Why it is called boot-shaped heart? Because the right ventricular apex goes up, it lifts the heart up. There will be concavity at the pulmonary segment because the pulmonary arteries are small or less blood flow through the pulmonary arteries, and most of the cases, almost like 25% of the cases will have right aortic arch. So that is the reason this gives a shape of a boot, which is called boot-shaped heart. Along with that, you can see there will be completely oligemic lung fields. If you do ECG, you will find the features of right ventricular hypertrophy with right axis deviation. Then the echocardiography is the most important and most common diagnostic modality to diagnose a case of tetralogy of Fallot, and most of the surgeons, based on this diagnosis, based on echocardiography, they decide about surgery. There are few exceptions which I'll come later. So what we are going to see on echocardiography? On echocardiography, we see the VSD, the size of the VSD, the location of the VSD, the number of VSDs. So all these information we'll get about the VSD. Based on that, we can plan what approach we can procure at the time of surgery. At the same time, it gives the degree of right ventricular outflow tract obstruction. Again, it has got various components: infundibular stenosis, valvular stenosis, supravalvular stenosis, or combination of any of them. So that you have to see what is the size of the pulmonary annulus, how are the branch pulmonary arteries. So these are various informations you need to get, whether there is any presence of aortopulmonary collaterals. So these informations you need to get on echo before taking a decision for taking off for surgery. Now, in which cases we should do cath? Surgery is, echocardiography is not enough to take a decision, or there are certain limitations for echocardiography. So first is pulmonary artery or coronary artery anatomy is not clear on echo. If coronary artery, pulmonary artery anatomy is not clear, definitely we have to go for either CT angiogram or coronary regular angiogram. Then suspicion of multiple VSDs, presence of MAPCAs. So these are and the suspicion of fixed pulmonary arterial hypertension. These are the cases where you need to do cath before taking off for surgery. Or else if the patient is presenting at a very late stage, then also you don't know about the MAPCA status, what is the pulmonary arterial hypertension status. In those cases, definitely you should, it is all institutional protocol, but usually most of the institutes, they do cath before taking the patient if the patient is presenting at a later stage. So what happens if you are not treating this tetralogy of Fallot? Many times patient comes from villages at a very late stage. Everyone in their locality suggested don't go for the surgery, there is no need, you cannot get cured. So usually those type of cases sometimes we see they don't come and come at a very late stage. So what happens to those cases? They develop cyanosis, deep cyanosis, of course not spells, deep cyanosis. They develop polycythemia because of chronic cyanosis. So polycythemia leads to brain abscess, stroke. Then they develop, because of chronic hepatic congestion, they develop coagulation disorders, stunted growth, hyperuricemia. These are the developments which happens at a later stage if tetralogy is untreated. These are the various associations. LPS stenosis, as I said earlier, 40%, bicuspid pulmonary valve is around 60%, right aortic arch is 25%, and coronary anomalies are around 10%. So this percentage is very important from examination point of view. This is an old article, but it shows how it happens, what will be the life expectancy and what is the survival if it is untreated. So in untreated cases, we see 3 years survival is only 50% and 10 years survival is 25%. Now coming to the treatment, there are two types of treatment, as all of you know, palliative surgery and corrective surgery. So when it comes to palliative surgery, again we have to go back to the same story, that who can know better than shunt. So this shunt can be of various types, as Blallock and Taussig first time described this shunt. Based on their name, it is called Blallock-Taussig shunt. So it can be classical or it can be modified. Classical was the one which was first done in the year 1945. That time what they did, the subclavian artery they divided distally and they rotated the subclavian artery and connected to the pulmonary artery, branch pulmonary artery. That is the classical Blallock-Taussig shunt. Nowadays very few people are doing that. Mostly it is not practiced nowadays. There is Waterston shunt, where the ascending aorta is anastomosed to the right pulmonary artery. Potts shunt, which is descending aorta anastomosed to the left pulmonary artery. So these are all now obsolete, or maybe very few people in certain exceptional circumstances they are doing. But mostly people are doing now the modified Blallock-Taussig shunt, where we put one graft, PTFE graft, in between the subclavian artery and the pulmonary artery, which is called modified BT shunt. So what are the indications? In which cases you should do shunt? Usually if you are finding any coronary anomaly which is crossing RVOT and you don't have option of putting the conduit at an early stage, multiple VSDs where you will love to wait for some time before doing the corrective surgery, pulmonary atresia presenting at a very early stage, generalized illness of the child, very distorted or small PA, premature and low birth weight, So these are the religious causes also. Jehovah's Witness, they don't allow you to transfuse blood, and if you are doing open heart surgery, you need to be prepared with blood. So that is the reason this type of things are very common in the Western world. They will come, they will say, no, we don't want blood. If you want to operate, you operate. If you don't want to operate, we'll wait. So that is the reason in those cases also we have to put a shunt, wait by time for few months or years, and then you can go ahead with the corrective surgery. Now usually the corrective surgery in most of the centers, it is practiced that it is done between 6 months to 1 year of age with flexibility, and in some centers they prefer as early as 3 to 6 months also, if the system supports, the infrastructure supports. And it can be single stage or it can be staged procedure depending on what type of system you are working with. So what are the various surgeries, what are the corrective surgery we do? If you see, the first thing is one of the component, as I said earlier, the VSD. So we need to close the ventricular septal defect. Along with that, we need to do the right ventricular outflow tract clearance. That means if there is any, this part is called infundibulum, this is pulmonary valve and annulus, and this is the supravalvular area. So there will be obstruction in this part because of hypertrophy of the septal band and parietal band. We need to excise the parietal band and septal band and make it wider. At the same time, we need to do pulmonary valvotomy and commissurotomy and supravalvular tethering release if the annulus size is normal. There is a nomogram. Based on that, we decide whether the annulus is normal or not, and based on the G score. And then we have to see how is the main pulmonary artery and what are the sizes of the branch pulmonary artery. So based on that, we can take a decision for corrective surgery. Close the VSD with patch. You can do interrupted pleated suture all around. There are many surgeons, they prefer this technique. I prefer continuous suture all around, and because that saves a lot of time. That is my way of thinking. So closure of the VSD is the first step, and then RVOT resection, excise the muscles, make the RVOT wider. If annulus is small, put a cut across from the main pulmonary artery up to the RV and put a transannular patch. Again, after putting transannular patch, there are two schools of thought. Few people thinks that there is no need for any valve to put there, and there are other school of thought where they put some valve, either monocus valve, bicuspid valve, which we create with Gore-Tex membrane, and put it there. Usually I prefer Sung repair, where I put a single anterior monocus valve, keeping the native pulmonary valve intact. I don't excise. Many surgeons, they excise the valve. I don't excise the native valve. I just incise the anterior valve and put the anterior cusp, and then over that transannular patch. Now, what is ideal tetralogy repair? Ideal tetralogy repair means at the end of repair there should not be any RVOTO, because that can prevent hypertrophy. Then there will be complete atrial and ventricular septation. That means there should not be any residual VSD. Avoid ventriculotomy because it can cause a lot of rhythm disturbances post-operatively and ventricular dysfunction. Preserve pulmonary and tricuspid leaflet competency. That is also very important, because if there will be PR, there will be TR post-operatively, the post-operative outcome becomes bad. It minimizes minimum early mortality and morbidity, freedom from reoperation, and good ventricular, good functional status and quality of life. These are the reasons why we should do complete repair at an early stage rather than staging it. Now, indications for early repair are why we should do. It is not indication, basically it is the aim, why to do it. Prevention of time-related end organ damage from cyanosis, because cyanosis can cause damage to all over the body to any organ. So before that stage reaches, if you are doing early tetralogy repair, we can avoid this. You can avoid right ventricular stimulus for right ventricular hypertrophy and fibrosis, and you can improve the lung development, and you can avoid the deleterious effect of the shunt, because shunt has got its own complications, distortion of the pulmonary arteries. So those things you can avoid, and a lot of psychological and emotional issues with the family. This is the survival chart, where again the recent one I didn't add here. So the 30-year survival is approximately 86% in case of tetralogy repair, and a recent article in 2023 it shows the 40-year survival is around 55%. So delayed complications of repair, because I am taking too much of time, I'll just skip these things. Delayed complications can be pulmonary regurgitation, aortic regurgitation, tricuspid regurgitation, pulmonary right ventricular dilatation, then residual VSD. So these are the mechanical complications, and electrical complications are heart blocks and various components of arrhythmias. So what to do in those cases? If there is any residual VSD, we need to correct it. How we will know residual VSD? If the shunting fraction, as some speaker said earlier, if QPQS more than 1.5:1, or if the size of the residual VSD is more than 3 millimeter, then we should go ahead and rectify that. If the right ventricular outflow tract obstruction is significant, systemic RV to systemic pressure is more than 2/3, then we should correct it. If there is any significant pulmonary valve regurgitation, patient is a bigger patient, there is development of arrhythmias or development of ventricular dysfunction, we should replace the valve with bioprosthetic valve. So this is a nomogram showing how to treat these patients. If it is duct dependent, go for neonatal operation. If hypoplastic PA, put a shunt. If adequate PAs are there, then do the complete repair at the neonatal stage. If ductus dependent is not there and patient doesn't have symptoms, wait for elective surgery. Hypoplastic PA, go for shunt. Adequate PA, go for repair. And if the patient is symptomatic, no ductus dependent, then follow this path. Thank you.
Thanks for your valuable lecture, sir. Now the stage is open to discussion. I request
Thank you very much, sir. One quick question for you, sir. I think tetralogy repairs numbers might have taken off since late 90s,
Right.
early 2000, last 2 or 3 decades. Are these patients coming for any delayed surgeries now? Who are
Yes.
doing these?
Usually the patient who comes for delayed surgery are mostly either because of arrhythmia or because of pulmonary valve replacement. Because if the patient is developing ventricular dysfunction, RV dysfunction, and arrhythmia, that is mostly due to the free PR. And usually in earlier days, nowadays many people, they put valves in the pulmonary position while doing the corrective surgery. But earlier days, when we were getting training or before that, usually people used to put only transannular patch. So now whatever patients we are getting, most of the patients doesn't have any valve in that position. So they are having free PR and developing the ventricular dysfunction. So mostly the patients are coming for pulmonary valve replacement. Many patients are coming for residual VSD, residual RVOTO, because in the mid age between say 2090s, 95 to 2010, 2015, many people used to do bicuspid pulmonary valve repair. But of late, what I am seeing that I also did many bicuspid valve repairs, but they come back with RVOT obstruction later, because if we are putting bicuspid valve either from pericardium or from Gore-Tex, usually they shrink, and over a period of time they develop RVOT obstruction, and they come back for RVOT relief. So those cases also we do RVOT resection. Along with that, we put a valve.
Sir, one small quick question to Chinnaswamy Reddy, sir. Sir, we all know that RV side is very trabeculated, whereas LV side is smooth. So did you ever consider closing VSDs from the LV side in case it looks multiple on the RV side?
But I do, but rarely. Actually now, no one indicates to do left ventriculotomy and closure, especially near the apex, where right ventricle is so much so trabeculated, cannot access, but can be easily accessed through left ventriculotomy near the apex. I do have closed in couple of patients, but I try to avoid doing left ventriculotomy now completely given up, especially after these catheter interventions. So I think many of them we can manage with catheter intervention.
Devices intraoperatively?
Yeah, Pop. Especially mid-muscular, we have done maybe 5-6 of them per ventricular device, intraoperatively. Intraoperatively, not on bypass. You have to go across the anterior wall of the right ventricle, identify, you go through, a transesophageal echo. Under the guidance of that, you need to pass a guide wire across the VSD and then place a device. So even some of these defects with apex, I think many times the cardiologists can manage this. But in the apex to place perventricular is difficult because one of the flange will be outside because there is no space to accommodate inside. I've tried that neo-endothelialization, okay. But sandwich pass technique, Dr. Amit what described, that's what you are telling about.
Yes.
Yeah.
Sir,
Did you
we
try
are
it?
having a 2-day session on tetralogy of Fallot. It's really, it's unfair.
No, that's
on
what
our
I
part.
said. See, I could not touch the aspect, surgical aspect of tetralogy fellow, decision making for taking up for surgery. So there are so many things at us, and a lot of articles are there to discuss. So because it was a teaching session for postgraduates, so I thought that I'll omit that part. And anyway, it is not possible in 15-minute time to cover tetralogy of Fallot, which is a long case for them to pass and make their career throughout. They should know about this. So that is the reason it is not possible to cover in short time. But as far as I know, whatever I could, I try to include in this.
Thank you so much, sir.
Thank you.
Sir.
First question, and my second procedure for tetralogy of Fallot, sir. Is it still relevant?
Ross procedure for
Brox.
Brox. Okay. So first question is, first answer to first question is still there is a role for shunt. Of course, preferably we should do complete repair even though patient is presenting at 3.5 months, 4 months time. If it is a neonat, then probably you need a lot of backup system to support this, which is not there with us. So I don't prefer to do neonatal correction before 3 months of age.
In our scenario, I think in our Indian scenario, see, there is no doubt any neonatal surgery carries higher risk than surgery during infancy. That is very clear. I'm sure I don't think it is worthwhile trying, neonatal intracardiac repair. Instead of that, you can go for either, PDA stenting or even RVOT stenting or balloon pulmonary valvotomy. These things can be tried, or neonatal shunt. Of course, neonatal shunt also carries somewhat higher mortality. Maybe at that time you can think of balance whether shunt versus repair, then you can think of that. But otherwise, it's better to avoid during neonatal. I don't think our setups are geared to do.
Right. Yes.
Definitely, prox is, suppose medically catheter interventions are unsuccessful, we can do prox procedure.
Not all units are geared up for neonatal.
Exactly.
No, that's what.
So our cardiologist is quite aggressive.
Even being a surgeon, even Dr. Chinnaswamy Reddy also will agree to this. It is not a good option to go for a stent, PDA stent. And the outcome is usually, as far as I know, in my hands, it is not good because whatever repair you do after removing that stent, it re-stenosed at that particular area. So that is the reason always I feel that if given the option that you are putting a stent in the neonatal stage or you are doing a neonatal shunt, yes, neonatal shunts are high risk, I agree, but still I'll prefer neonatal shunt over stent.